we'll be moving on to our next session quickly. It's a very important panel discussion. May I request our chairperson, Dr. Shubhadeep Chakraborty, surgical oncologist, and Dr. Ellen Bishwas, sir, radiation oncologist, to come to the come to the stage for chairing the session. May I request Dr. Shuparna ma'am also to join the session? Over to you, sir.
So now starts the panel discussion on one of the hotly debated and most extensively discussed topic in the recent times, and that is neo-adjuvant therapy in rectal cancer. This is a panel discussion, and my duty is to introduce the moderator. The moderator of the discussion is Dr. Parth Desai, who is a clinical oncologist at Royal Preston Hospital in UK. He has been trained in Christie Hospital, Manchester, and with special interest in breast and colorectal cancer. So I think my colleague, Dr. He will introduce the panelists.
Good afternoon. It is my honor to invite for the panel discussion on neo-adjuvant therapy in rectal cancer, Dr. Samima Islam, Dr. Shogat Podwal, Dr. Arvind Kumar, Dr. Amitabh Ray, Dr. Manu Prasad, Dr. Kaushik Bhattacharya, Dr. Trinanjan Basu, Dr. Nikhil Agarwal, and Dr. Anish Bandyopadhyay. So with the permission for all the chairpersons, we can start. I will request Dr. Parth Desai to start.
Hello, good afternoon for India time and still morning here. And thank you, Animesh, for inviting me. It feels quite humbling to speak in presence of three of my teachers. Dr. Cooper, thank you for all your leads courses for our FRCR exams. Dr. Radhakrishna, I would not try to say anything about SABR, I promise that. And Dr. Datwari, I read your name somewhere, but I can't see you, but my best regards and wishes for you for New Year. What I have here is sorry, Animesh, how do I move the slides? Thank you very much. So it is just about deciding what is the new standard of care for rectal cancer patients. What we have seen recently is that, at least in UK here, there are loads of patients who are stoma averse. And we now have new trials, and Dr. Cooper has already covered Prodigy 23. She has covered the other trials. But essentially the question remains like, how do we go about it? The standard short course radiotherapy, long course chemo-radiotherapy, short course radiotherapy, and then wait and watch for patients who are quite elderly or of poor PS. And we have come a long way, going from 90s trial where the surgery was the only option and the local recurrence rate was as high as 46%. And then the Dutch trials from early 2000s where surgery and a standard TME, total mesorectal excision, we started to achieve a local recurrence rate of just 5.8%. So we have come already a long way in terms of managing rectal cancers. Can I have the next slide, please? So ultimately, this is what we do in general. We are guided by the pelvic MRI and we consider what is the risk of local recurrence. I'm sure the panel as well as the audience already know about this, but it is essentially the risk factors that we look at about trying to achieve a good surgical resection. R0 resection is our ultimate aim. T3 disease, not necessarily unless it is more like T3C or T4. Low rectal cancers where it is almost touching the levators and you are considering possible ending up with a stoma for life, vascular invasion, or high lymph node burden. And based on that, we can divide them in the three categories. Either they go straight to surgery or short course and then surgery, or long course chemotherapy and surgery. This has been the standard of care for a few years now. Can I have the next slide, please? So this is what we do in general at most of the centers. Short course radiotherapy, 25 fractions. And we do see that about 5 to 10% of these patients, especially the low stage ones, do get pathological complete response with this alone. For long course chemoradiotherapy, the pathological complete response is slightly higher. I would just mention here that for my center, we do capecitabine on the days of radiotherapy. And I understand that Christie and possibly Clatterbridge does it for all throughout the treatment. New concept emerging is long course chemoradiotherapy with boost to the lymph nodes, where we are going as high as up to 54 gray in 30 fractions. Ultimate aim remains that of pathological complete response with these ideas so far. Can I have the next slide, please? The new aims that we are now talking about is what is the quality of life, organ preservation, and avoiding stoma. Quite a few of the patients are coming to clinic who are in their 60s or 70s, and they absolutely don't like stoma. Quality of life is important because for us, when we say that, well, you might end up with a long-term toxicity of grade 2 diarrhea, it sounds like a simple thing to us, but living with diarrhea where they constantly have to be on the lookout for a loo is not exactly a good quality of life. And organ preservation, as it has been heavily discussed in cancers like bladder cancer as well. Next slide, please. Dr. Cooper has already covered most of the things, but I will just highlight on the main things that 2015 onwards, we have had multiple trials which has looked at total neoadjuvant treatment in the form of giving long course chemoradiotherapy and some additional chemotherapy before we proceed to surgery. The standard of care, we are achieving about 15% pathological complete response, especially for lower stages with long course chemoradiotherapy alone. The debate is on the extent of how far do we push it, long course chemoradiotherapy, and then how much of chemo is better. And we are looking at what is our ultimate aim. Is it pathological complete response versus disease-free survival? And more importantly, if we can achieve a disease-free survival of anywhere between 40 to 80% over a period of 3 years, that is also meaning that the patients are living for 3 years without the need of surgery. Can I have the next slide, please? So Rapido trial back in ASCO 2020 suggested that short course and then 9 rounds of FOLFOX achieved pathological complete response of 28%, but again, this was doubling the grade 3 toxicities. Stellar in JCO in 2022 suggested short course, 4 rounds of Capox, and then it did achieve a good overall survival. It increased by about 15%. Polish 2 trial suggested short course and FOLFOX, again, quite similar to Rapido. All of these trials are definitely at high risk of grade 3 toxicity, which is almost double for most of these patients. Next slide, please. So Rapido trial is what is, Dr. Cooper has already said this, but this is what we are standardly following because patients tend to tolerate it relatively better. And we do achieve a better disease-free survival at 3 years. Although there is no clear difference in R0 resection between the short course versus long course in a total neoadjuvant setting. Next slide, please. Now, Rapido versus Prodige 23, this is the ultimate debate. Rapido has been found to be better for disease-related treatment failure, chances are better. Prodige is better for disease-free survival. There is no difference in overall survival, and long course chemoradiotherapy is better for local relapse, but OS, overall survival, is not statistically significant. Next slide, please. Ultimately, when we have all these trials, we are looking at what is the best course of action in that case. And I think the patient selection ultimately is the most important thing. I've got about 6 patients on TNT treatment right now, but they are between the age of 30 to 50 with a performance status of 0, and they are very fit people. And somehow it is the oxaliplatin that worries me more. They start to fall apart after 4 or 5 rounds of treatment. Long course chemoradiotherapy, followed by chemo, followed by surgery, we are achieving much higher clinical complete response rates, and that is better for patients who are quite stoma averse. And at Preston, we are basically following short course radiotherapy, followed by 9 weeks of FOLFOX, which is my particular preference instead of Capox, and then followed by surgery versus observation. Next slide, please. We don't know what is ideal. I think based on fitness, age, comorbidities, I think that question remains open to all. Short course and delay remains an important choice, especially as we saw in Stockholm 3. Hi, can you hear me?
Hello.
Sorry.
Can you hear me? Yeah, Dr.
I can hear
Desai.
you. Sorry.
Yeah, Dr. Desai, there are a lot of panelists waiting, so we would suggest that you ask, involve them in the panel discussion also. It's becoming
Absolutely,
it's a
absolutely. I
one-to-one.
got about two more
one-on-one.
slides and that is done. So it
Yeah.
is open for discussion. Yeah.
Yeah.
And long course chemo-radiotherapy for relatively unfit patients. And it is ultimately the discussion between consultant and patient. Next slide, please. Dr. Cooper already mentioned that what happens to the patients who achieve clinical complete response, what do we do with them? And we do have Encore study from Northwest by Professor Renahan. And in that 80% of the patients didn't recur at 3 years. And even when they did recur, they were still solvable. So stoma and quality of life remains a big factor for patients' decision in these cases. Next one. Surveillance, it depends on what is available at the local center and what the patients are willing to pay. Next one, please. Currently under investigations are multiple other things, but I think Dr. Cooper has already touched on most of these topics, and I would leave it for the panel to discuss. Animesh, I'm happy to conclude here, and I would prefer if we can carry on conversation more openly. Sorry, Animesh, can't hear you.
Can you hear me now?
Yes, we can.
Parth, it was supposed to be a panel discussion, and there are a lot of panelists over there.
I'm so sorry. I just thought I would give a brief outline. Dr. Cooper had already covered it, and
Okay.
this is just what we have so far, and I would be much more guided by the panelists now.
I would request you to ask questions to the panelists regarding
Of
their.
course. Of course. So in terms of the panel members, can you please share what is the local practice that you follow and what rationale do you discuss with your patients?
Can you hear me? In our practice, especially in parts of Bihar where I practice, the rectal cancer is more common in the younger patients, 25, 30, 20 years. We have patients in this age group. So I generally follow the PRODIGE 23 to TNT with modified for Frenox. These are the younger patients, they tolerate, and their disease biology is very bad. Means high grade tumor, poorly differentiated rectal cancer we have commonly. So in my routine practice, I follow the PRODIGE 23.
In those patients, sir, do you also do repeated CT scans intermittently just to make sure that the disease has not gone metastatic in the meantime?
I often do, but not as a routine practice routinely.
In terms of PRODIGE versus Rapido, do you have any particular preference for any specific other reason? Your population is young and fit, which is fantastic.
Yeah.
But you consider Rapido for any other specific group of patients?
Rapido, yeah, for those group of patients, means actually, see the radiotherapy dates, some constraints are there. So,
Sorry,
for
Dr. Kumar, I don't think I can hear you, but
yeah, can you hear me right now? Hello, can you hear me? Hello.
Yes, sir, we can hear you, sir.
Yeah. I just want to make my point that another reason for me for going for PRODIGE is that meanwhile, while the patient is on chemotherapy, the radiation dates are so prolonged that my patients they don't get their dates delayed, because if I go for Rapido, then if I have to wait for another 2 to 3 weeks for radiation to start.
of course.
So, Dr. Parth, like here, obviously, rectal cancer treatment is very much individualized. And as we discussed, these TNT protocols are not for each and every patient, especially the patients who are old and who are not very fit. So obviously the standard of care had been long course chemoradiation, and some of the patients will be fit for that. Now, specifically coming to Prodige versus say Rapido, right? So Rapido is one of my favorite protocols, actually, if the patient can tolerate, because the treatment duration is short and stoma duration is shorter, right? And we can quickly do away with the treatment, slightly higher toxicity, but tolerable. Now, specifically a patient where there is a contraindication for short course chemoradiation. Say, for an example, sometimes we see a patient where the disease extends from rectosigmoid junction to lower rectal cancer, or there is so much sphincter involvement that my radiation oncologist will say that I cannot give short course radiation because I will want to radiate the inguinal region as well. And there are some more contraindications for short course, which radiation oncologist will enumerate more right upon. So in those patients, I would want to do Prodige 23 in a fit patient. And one more subgroup of patient where I would be more happy to do Prodige 23, where I find the patient more at high risk of systemic failure, right? Say, for an example, if there are nodes along the IMA, right? So I see these patients at a high rate, and though in in Rapido, we can start chemotherapy after say around 3 weeks, but we get one higher, more effective chemotherapy in Prodige 23 by giving FOLFIRINOX, and 2 we can quickly start it. So these are the group of patients probably where I would want Prodige 23 compared to Rapido.
Thank you, Dr. Agarwal. Dr. Islam, would you like to comment?
Actually, regarding choosing of short course or long course radiotherapy, actually, I go for considering some factors. That is the patient-related factor. If the patient age, performance status, and the comorbidities, and also the patient choice. And for the tumor-related factor, I consider the tumor bulk and the extent of nodal disease. And institutional factor, actually, I go for the experiences and for the pandemic condition. So most of the time, actually, we prefer the Prodige 23 trial. We go for the long course radiotherapy in that case, actually.
And whether you choose Rapido or Prodige 23, any form of TNT, do you find most of the patient managing to complete the standard protocol?
Yeah, I think so. Actually, Prodige 23, we go for the long course radiotherapy. We go the 50.4 radiotherapy in 28 fraction. And after that, we previously go for the chemotherapy and then complete the total neo-adjuvant treatment, and then assess the patient with the MRI of lower abdomen, either if there are any complete or partial response over there, and then go for the surgical
because
option.
that remained one of the concerns with all these TNT treatments. Like MAGIC trial for gastric cancer was fantastic, FLOT for esophageal is fantastic, but ultimately it comes down to how many patients do actually manage to complete the whole treatment.
Actually, it's a matter of time. Actually, we are previously we just treat the locally advanced cancer patient, rectal cancer patient, with the neo-adjuvant chemo-radiotherapy followed by surgery, and then according to the histopathological reports, we go for the adjuvant chemotherapy. But very recently, we just shifted after that Prodige 23 and Rapido trial. We just shifted to that total neo-adjuvant treatment. So actually, the overall response we cannot. We are just following that patient in a very short duration of time. So right now, actually, I cannot conclude about the complete scenario, but I think it will take some time to get the proper outcome of that treatment.
Okay.
I think we also got Dr.
Can
Shogat from Nepal, Dr. Manu Prasad, Dr. Triranjan
Yeah,
Pashu, and
I'm
Dr.
sorry, I
Anish
can't
Bhagwat.
see the other gentleman on the line here or on the video. Please speak up,
Hello.
sir.
Yeah, I'm Dr. Manu Prasad. Actually, I practice in a center in South India. So we also follow something like a rapido protocol. So most of our patients get short course RT and then K-POX based chemotherapy. And in select patients, as the previous panelist has already discussed, those who had a bulky disease, in the locally advanced disease, probably they'll go for concurrent chemoradiation. And regarding the Progis 2 strategy, that is very reserved for a few patients who do not respond well to the concurrent chemoradiation. So only in those patients we go for a triple drug regimen. Otherwise, we generally follow the rapido protocol. So this is our practice.
So hi, I'm Dr. Basu. I'm from Mumbai. I'm a radiation oncologist. So for our, so finally it remains, of course, you have to discuss with Medonc and the surgeon, because the surgeon roles is very important, what they're trying to do. And you really need to tell your patients as well, whether they're opting for a TNT proper or they should be aware of the risk, because there are logistic challenge to it. If you have to keep a patient really on TNT, the investigations goes at times too much for the patient. Another challenge in a diverse scenario in India is many a times people after their first or second, say the scopies and the MRI coming well, they tend to drop off in follow-up, which is a very risky thing to happen in a TNT approach, because there will be chance of local regrowth. So that one needs to understand very well. In our center, the Rapido is quite famous. So as radiation oncologist, where I would not maybe force for Rapido, like for short course. So we do short course with definitely IMRT. There are UK guidelines now to follow for bowel and bladder constraints. So one needs to really follow that doing. Personally, I feel though 25 in 5 is less, people are trying to explore 13-5 now, because if you calculate EQD2, you're really not achieving a very high dose in 25 in 5 compared to doing a 15-25 or even trying to do a lateral pelvic nodal boost. So yes, where we need to treat the inguinals, where the disease coming to the low rectum involving anal canal or a lateral pelvic node, we would try and refrain doing a short course, try to put for long course them. Otherwise, Rapido is a good protocol. It's quite well tolerated, and especially for mid to upper rectum with bad biology like signet, young age, it's good to complete the short course because their local symptoms settle well and then send for the chemo, because eventually that is what is required in them, because they'll have more systemic failure than local.
When we have, I think we have a medical oncologist in the panel as well. Sir, do you have any opinion on these MSI high group of patients?
I think Dr. Arvind Kumar and Dr. Manu Prasad are medical oncologists. Can ask them the question.
We did not actually get the answer from the panelist to that question put by Dr. Desai. What proportion of patients can actually complete the protocol, Rapido protocol, or what proportion of patients?
I would like to answer this question. Myself, Dr. Anish, I'm working in a government medical college, and we are doing Rapido quite regularly, and I can say about 80 to 90% complete them quite safely and quite comfortably. They complete it, and we are getting very good. It's part of a study. We are getting very good response, PCRs. So it is well tolerated, Rapido.
And within that, sir, do you have a particular preference of using K-POX versus FOLFOX?
We prefer K-POX because it's logistically superior, and it is 6 cycles of K-POX. We prefer that. FOLFOX, you need admission, and K-POX we can give it in daycare, so we prefer the K-POX.
And do you come across many patients who essentially ask for this type of treatment or TNT in the name of organ preservation, or who don't want stoma, or is it not so common for your practice?
See, the type of patients we see and the setup we have, we actually get patients who already have a stoma, emergency stoma done before neoadjuvant therapy. And patients would love to have a stoma-free, disease-free survival. We don't opt for organ preservation routinely for, say, suppose our elderly patient, a patient who is not willing for surgery, we at times go for that. Otherwise, it's not a routine.
Dr.
Hello,
Paudia,
Dr.
sorry, are you,
Anish.
sorry.
Dr. Anish,
Yeah.
you told that you prefer a rapido trial and you practice it in the hospital, but you give capox 6 cycles with short course radiotherapy. That is actually not the rapido trial, isn't it?
Rapido had both the things, capox and Folfox.
I think we also got Dr. Shogat Podial from Nepal. Can we ask Dr. Shogat to give his views about the practice that they follow in Nepal?
Yeah, thank you, Dr. Animesh. Hello. Hello, am I audible?
Yes, you're audible.
Okay. So actually, I work in a government setup here in Nepal. So in fact, there are problems with the radiotherapy dates with us. So although I'd like to practice with the Rapido, but there's been a due to the waiting time, it's quite impossible. So we do practice for fit patients the Protis kind of protocol. We start with chemotherapy, followed by take a date for the long course chemo-RT, then go for surgery in such cases.
Thank you, sir. I see a hand raised by Dr. Mohan Hingorani.
Yeah, hi, sorry. Yeah, I'm not part of the panel actually, but I just wanted to express my views. So I'm a clinical oncologist, I think, in UK and in Hull. So we have actually spent a lot of time trying to develop some guidelines for with all these TNT protocols coming in. So we kind of got together, I think it was Leeds, Sheffield, and Hull. So what we felt was our experience is that I think TNT protocols are pretty effective, but we have to understand that they have a role mainly in patients with T4 and N2 disease. That's where the real benefit is seen. But you have a locally advanced group of rectal cancers who don't have T4 and N2 disease. And basically that's where, because I think what's happening is that with the locally advanced rectal cancer, means with these TNT evidence coming through, I think we are kind of as default adopting TNT protocols. We can't get away from the fact that these are toxic regimes. And Pradesh is actually pretty toxic, and a lot of patients with rectal cancer in our centers are elderly who can't have Pradesh. So our TNT default option is actually Rapido. But having said that, there's still a group of patients who have, say, T3B or T3C disease, where you would probably consider some form of neoadjuvant therapy, but they haven't got any lymph node, significant lymph node disease. Maybe they have 1 or 2 lymph nodes, which the radiologist would probably put down as saying probable N1 disease. So in those patients, we don't use TNTs. We're still going for short course followed by delay, because there was evidence, there was a study of short course followed by immediate surgery or short course followed by delay, which showed that delay actually does not compromise outcomes. So we still have a role for short course radiotherapy on its own. And we also have a role for long course on its own. So like somebody who's got T3C disease with the threatened CRM and limited nodal involvement, we would still use long course on its own. So we have actually got divided groups where we use short course alone, long course alone, or the TNT protocols. But if you were to use TNTs, we'd probably prefer Rapido because Pradesh is very toxic. The final comment was that this thing about radiotherapy dates is not actually is a problem in our center as well. We've had a crisis now. We've been really struggling to get radiotherapy dates. So what we decided as a team was like the Rapido has short course followed by chemotherapy, but where we can't get the radiotherapy dates on time, we start with chemotherapy, use capox for 4 to 6 cycles, and then give radiotherapy. So you can get around that. So this thing about you have to have a short course followed by chemotherapy. I think it's, yes, the trial protocol said that, but there's a way around that where you can give chemotherapy first followed by radiotherapy. Thank you.
Of course. Yes. Can I just ask an open question to the panel and also Dr. Hingrani? Where do you see the lymph node boosting in the context of TNT? Because we started to think about lymph node boost as a SIB for lymph node positive patients. And the standard dose of 45 and 25, we are pushing sometimes up to 54 in 30 for that integrated boost. Do you consider those patients to be able to tolerate TNT, or do you think we are just putting too much pressure and trying to increase a bit more grade 3 there?
So are we talking about nodes, mesorectal nodes? We're talking about pelvic sidewall nodes? What nodes? Because
we are talking about pelvic sidewall nodes, which we
okay.
started to boost. Yeah.
Yeah, so we do that actually. I think we sometimes do that if we think, because I think if you have a pelvic sidewall node, then that's outside the mesorectal envelope. So that doesn't come in part of the standard TME surgery. So what we have got, we have a surgeon in Leeds who would actually do a pelvic sidewall lymph node dissection. So in those patients who we think are suitable pelvic lymph node dissection, we would go for a pedo because you can still give them short course. But if you think the patient is not fit for sidewall lymph node dissection because of comorbidities and all, because it's a major surgery, we would then probably go for long course and chemotherapy, because with long course you can boost it, with short course you can't. There's no protocol where you can boost the sidewall with the short course. So if you're trying to boost the sidewall node, we would go with long course then, plus minus chemotherapy.
Absolutely. Do you have any comments from any other panelists, please?
Yeah, we do that also for if you have extra mesorectal nodes, pelvic sidewall nodes, then if you are planning to boost, then yeah, we do a long course, same, maybe a 50-25 to the whole thing and 54-25 as a simultaneous integrated boost.
Fantastic. And for this proportion, quite a big proportion of patients with the TNT treatment, whichever route we take, are getting clinically complete response and the endoscopy doesn't show any viable cancer. How do you go forward from that? Do you prefer a period of surveillance, offer them surveillance, or would you still prefer to go straight for surgery because it was a nasty disease at the outset? What I'm trying to ask is, what do you consider as your main goal with some of the patients? Clinical complete response or pathological complete response?
Pathological.
Well, I think, so I think in our center, actually, we're using organ preservation. It's not a standard of care, but somebody wants to avoid a stoma and they don't want surgery. We would say that if you had a complete clinical response at 3 months, you could potentially go on to the organ preservation protocol, but we emphasize that's not the standard of care. We also emphasize that the clinical complete response at 3 months does not mean a true response, because you'll have to go on a period of surveillance, which involves 3 monthly sigmoidoscopies plus minus imaging, and 50% of those patients will relapse within 2 years. And so they need to know that that's not a curative treatment. So having a complete response 3 months does not mean they won't have surgery. So we are developing kind of our patient information leaflets and clear guidelines to manage these patients, because there is data out there, but there's no randomized data to support it. And that's where the patients need to understand that this is still an experimental form of therapy, but Brazilians have been doing this for ages without compromising outcomes. So we are using it for selected patients who are not fit for surgery, or who really want to avoid surgery. So we have a protocol for those patients, but that's not based on randomized data. That's based on the multiple single center series which came out about organ preservation. And in those patients, I think they would still have the neoadjuvant therapy as would be standard. And then if they want to avoid surgery, we'll stage them at 3 months and take it from there.
Thank you very much.
Dr. Desai, thank you. Just like a surgeon, I'm intervening at the moment. So we are at a shortage of time. So it was a very intricate discussion amongst all of us. So it has given us an insight in the neoadjuvant therapy in rectal cancer. So with this, we come to the end of our discussion. Thank you.
Thank you. Thank you, Parth. Thank you for the moderation. And thank you, Samina Islam, Dr. Shogat, Dr. Arvind, Dr. Manu Prasad, Dr. Triranjan Basu, Dr. Anish Bandyopadhyay, and Dr. Nikhil Agarwal for participating in the panel.